So I have the honor of introducing Dr. Alegría, who is the chief of the Disparities Research Unit at Massachusetts General Hospital and the Mongan Institute. Harry G. Lehnert Jr. and Lucille F. Sire Lehnert Endowed Chair at the Mass General Research Institute and professor in the departments of medicine and psychiatry at Harvard Medical School. She has spent her career examining how to reduce health disparities for populations of color, immigrants, and linguistic minorities. Dr. Alegría is currently the PI of 3 National Institutes of Health funded research studies: building infrastructure for community capacity in accelerating integrated care, building community capacity for disability prevention for minority elders and Latino youth, coping with discrimination, multi-level investigation in micro and macro time. She's also PI of a Robert Wood Johnson Foundation grant assessing opportunities to establish institutional policy and systemic changes to increase racial ethnic diversity in academic health centers. She has published over 300 papers, editorials, intervention training manuals, and several book chapters. In October 2011, she was elected as a member of the National Academy of Medicine in acknowledgement of her scientific contributions to the field. She's also been a recipient of notable awards such as the Simon Bolivar Award by the American Psychiatry Association, the Rema Lapus, I apologize profusely for mispronouncing these names, by the American Public Health Association in 2020, and Lifetime Achievement Award for Latino Behavioral Health Research for the National Latino Behavioral Health Association in 2021. Most recently, she's received the 2022 Inclusive Voices Award by the American Association for Public Opinion Research. She's obtained her BA in psychology from Georgetown University in 1978 and her PhD from Temple University in 1989, and has a prolific career. We are very honored and excited to have you here today. I'm going to go ahead and mute myself and pass the mic over to you. Just know that I'll be tracking any of the questions and chats and comments in the chat, in the DMs. You don't need to do that. If you want to, you can, but I will be helping you with that. Okay.
Thank you so much, Barbara. This is a super opportunity to be able to present to you, and I'm very excited. This is work by our team, I should start by saying. And so I'm very excited to represent my team here and the work that I'm going to walk you through. First thing I want to say is we have no conflicts to disclose. This is all work that has been funded by the National Institute of Health. This project in particular that I'm going to be talking about has been funded by the Robert Wood Johnson Foundation. The agenda that I had for you today is really covering 4 areas. I wanted to first talk about minority youth statistics that we have, and maybe someone could mute because I'm hearing a lot of sounds on the background, so that would be helpful. So let me say that I'm going to cover 4 areas. I'm going to cover minority youth statistics. I'm going to tell you a little bit about framework that I think is really important to ensure that whatever we do, we can improve the mental health of youth of color. And then I'm going to tell you about PhotoStories, which is a very different approach to how we develop interventions for youth. And finally, I'm going to go to LEAD, which is basically the actual intervention that we developed. Let me say that these are the basic objectives that we have for today. Our hope is really to be able to, that you can identify at least 2 benefits of why asking youth to be co-researchers and get their perspective can be so important to enhance youth health promotion science. Why do we know that getting youth input in this benefits of co-creating the interventions has a benefit of enhancing themselves? The second thing is really to explain how maintaining a focus on youth perspective and priorities can function as a valuable tool in the practice of community engaged research. And this is going to be a topic that I'm going to be talking a lot today about, the importance of going to community and engaging in community when we are deciding what we're going to do in terms of research. And finally, I'm hoping that you can describe one potential strategy for how to incorporate co-creating solutions with youth in clinical practice. Let me start with the minority youth statistics. And I don't know if it's possible to mute.
That person. I think maybe Barbara, is there some staff?
There,
No,
I don't
can you
have-
see it, Barbara? I can see Anna Agneta is not, there's no mute there. I don't know if that,
I think it's L Wong, actually, Marina. The sound keeps coming from them. I don't know if there's some staff that can mute everybody and then unmute Margarita.
I don't have mute and unmute privileges.
Don't worry about it. Don't worry about it. We'll do our very best. That's not a problem.
Oh, sorry.
No, that's fine. So let me just go very quickly. I wanted to show how there's two patterns in terms of the percentage distribution of race and Hispanic origin that we saw in the 2020 census that I think it's really remarkable and something to very much think about. The first one is what a big increase since the 2010 census there has been in youth being identified as having two or more races. And the other one, as you can see here, is the big percentage of youth that are of Hispanic origin that are under the 18 years of age. You can see there it's almost 26% of all youth that have Hispanic origin and 15% of youth that sort of are identified with two or more races. I also want to show you the projections because the projections in terms of how the landscape of youth in our next decades is going to change dramatically. It should be something that we take into account. The first one has to do with looking again to see in 2016 that we expect like 32% of youth will be of Latino origin, 16% will be Black youth, and then we have a big percentage, 8.1% also of Asian youth and 13% that are all others. But this means that if you think about it, this is going to be a very diverse group of youth that we would have. I also want to emphasize the importance of getting information of immigrant youth, because the rates, as you can see here, the whole immigrant population is almost 47 million. And this is remarkable in the sense that they represent 14.2% of the population as of January 2022. But the importance in here is, again, in many of the studies that we're seeing in the literature, they're not included, partly because there's no language capacity when people do some of the research to include the other languages besides English. But we should take into account that immigrants will represent a big share of the population. I think this part is one of the most important pieces. I mean, things have been going, unfortunately, downhill. Some people mark the date as 2012, where we are seeing dramatic changes in adolescent mental health, all the point to becoming a crisis, where the US Surgeon General had to put an advisory for especially how many emergency room visits for suicide attempts were seen by girls, particularly a 51% increase of higher than 2021, in early 2021 compared to 2019, and 4% higher for boys. But you can see here that it's an escalating mental health crisis that we really need to attend in changing what we're doing right now. And I also want to emphasize that in this report, they really talk about the challenges during the pandemic for minority adolescents. You can see here, this is data from Child Trends, and it shows, you know, the mental health conditions are on the rise comparing 2016 to 2020. And again, you can see here, you know, for example, American Indian or Alaskan Native going all the way to 15% of youth who had anxiety or depression. You can see here Latinos, almost 12%, but a big increase since 2016. And again, you can see here the rates for two or more races, 13%, also showing bigger trends in terms of having anxiety or depression. The national surveys that have been done during the pandemic have also showed that 72% of high schoolers are reporting poor or decreased mental well-being. And this is very important because we know that there was a lot of academic loss, but I also think many people are concentrating on the academic loss at the expense of a lot of these youth really are struggling with mental health issues, particularly the Latinx community, as you can see here, with really, compared to white youth, the Latin youth were 60% more likely to report poor mental health. I think this has a lot to do with how people are thinking about context and where they're living and how they're really experiencing their context, both their social context as a minority versus a majority, and where you live and what are you, if a majority or a minority, really has a tie to your self-worth, to how people see stereotypes in you, and how you deal with traumatic events. I think this is a time when youth feel that they have less control compared to the majority, especially if they're in a minority context, and how they can really not have a great sense of the control over their own situation. And this uncertainty can put them at risk. I want to also, and I know many of you know about it, but I want to make the difference between minority and minoritized, because minority it's a social construct, or although many people think of it as a fixed construct, but it is a social construct, typically thought as being a mathematical minority, but also it's really tied to your skin color, to how you're different by culture, how you might be affiliated to a group that has limited political, economic, or social power. I think minoritized is what we are using now, because we want to change the language in terms of this is this social process whereby groups in the majority might exert exclusionary practices so that they result in historical and contemporary racism that really takes away the opportunities and resources from groups that are in the minority. But it's really the action of taking away those opportunities. I want to say that beyond being minoritized and being exposed to what we were talking, stereotypes, structural racism, limited opportunities to thrive. If you look here, I want to show you, this is the percent of youth receiving mental health services in the past year. And this is data of SAMHSA of 2019. We don't have a newer version of this, but I do want to show you that the rates that really most of the specialty care is really specialty mental health in specialty mental health settings and the educational setting, but this has not been as dramatically increasing as the need has increased. So while the need of more resources is going upward, the actual supply of resources and services is staying fairly stable over time. And this is 2002 to 2019. If you look, for example, general medical care, the pediatric setting, it really is not providing a lot of mental health care. And this is an area we're going to talk about. And also, you can see here the juvenile justice or child welfare is actually not offering that much at all. I also think I want to emphasize that we are seeing a trend of services increasing for girls, but actually decreasing for boys. And I'm very worried about this, about boys, because you will see that there has been escalating problems in terms of the mental health of boys. And one of my concerns is that the types of offering that we're giving in terms of mental health for boys is not aligned with what they want. And therefore, especially for Black adolescents, we're seeing a a decrease from 22.6% of receiving services to 18.5%. And so we are seeing a decrease in certain groups of youth of color receiving less services and seeking less services. Even if you seek care, you can see this Cummings article that there's widespread disparities in terms of getting good care. In this study, you can see that, for example, minimally adequate care, both Black and Hispanic youth were significantly less likely. And this is psychotherapy, having 4 or more visits during the year. And white youth are more likely to receive it compared to Black and Latinx youth. But you can see it for pharmacotherapy. You can see it for either pharmacotherapy or psychotherapy. So overall, we're having that youth, both Black and Hispanic youth, are receiving less minimally adequate care. I want to show you one thing why I think this is, and this might be one of my biggest message today, the importance of moving higher upstream in terms of what we can do if we're going to change what we're having right now. Most of the work we have been doing in this area has been in secondary prevention, a little bit in primary prevention, but very little at the system and community interventions. But if you really want to change the way we're really moving forward, you have to deal with health policy and system and community interventions. And that's what I'm going to talk more about. We published a paper this year talking about how to think about culture and contextual forces and how they impact youth, and why we have to think wider than secondary prevention, and how the importance of people that are in the mental health field to really be aware of all the forces that are having an impact. And here in this paper, we talk about what needs to change. How can we change in a different way of how we're providing care? I think the model is just not working. We talk in this paper about policies that could be used to improve the mental health of youth that are central, and I'll talk a little bit more about them later on, but the importance of, at the level of the system, to change policies at the level of the system to see if we could really include more multi-level and multi-system interventions rather than just individual level interventions, which is what we have been doing today. Thinking more of neighborhoods as areas of intervention that really impact a lot of the physical and social environment of youth, and where we could have a bigger payoff because we're impacting more youth by giving them opportunities for prevention and remediation. And then obviously the issues that, how can we reduce childhood adversities that are so central in the well-being of youth. Unfortunately, if we don't think about the environment of youth, and that most of our minoritized youth are likely to reside in disadvantaged neighborhoods that are typically, full of, high levels of stress. And I mean, I'm not presenting all the studies that we have done, but some of the studies really show how when you're in a minoritized environment, the stress by, exposure to violence, but by other types of stress, like uncertainty of how you interact socially, creates an impact in terms of the children's brain development, and how this also ties into a family that's undergoing a lot of hardship. If you think that according to studies on the economic impact of the recession, for example, Latino families lost 40% of their wealth. Similarly, Black families lost, I think it was 32% of their wealth. So you're thinking of families that throughout the recession and coming up to now have been undergoing a lot of economic hardship, and that leads to food insecurity, housing instability, things that really are central. In this paper that we published in 2018, we talk about how the need for social determinants should be a big piece of what we do. And this is a paper that has been cited tons, and I really was surprised by it because I thought that this is something we've been talking for a long, long time about the need that when we're talking about mental illness and trying to really think of interventions, how can we put, the social determinants as part of the intervention development? So for example, in many of our studies now, what we are doing is we have social determinants for everyone. We have care managers that even for the control group provide social determinants as a piece of what everyone needs if we want to improve the mental health of youth of color. I also want to, as I said, I think we have less evidence, but more possibility of thinking about community level interventions, especially those that target the built environment, but also those that have to do with how social interactions can be done in a better way to make sure that youth feel included in their communities and can be leaders of their community. And then the importance of integrating social service in primary care and get youth in primary care very early identified and serviced. Let me tell you about PhotoStories and the importance of co-creating solutions to reduce disparities. I want to say that this was a very different way of the work I've been doing. I've been doing, I would say, at least 20 years of intervention development. And all the while, I mean, the model has been to actually think of what's needed and then work some with community on the development, but this was a very different experience. Let me say where we started and why we did it so differently in this way. We had just finished a study showing how where youth live is very local, and how that local environment is the setting where you can understand the interactions of social support, where you can understand the social exclusion, the interpersonal relationships that youth have, and the perceptions and attributions of their social position in the community. It's where you can see how social stratification and segregation play out, both residentially, psychologically, and how the environment can be either an inhibiting or an enhancing environment for youth. And really trying to capture that is so central, because that is where we think a lot of the development of youth doing well or youth doing poorly plays out. And so really understanding how that neighborhood plays out as a local matter for youth, how they experience it, how they really interact in that environment, and how embedded it is in the life of youth. It's really, substantial and takes time. And so it also, that environment has a history, and sometimes we really don't understand the history of the context where kids interact. What's the space like, and what are the relationships that they have access to in that environment? So to do that, we use Photo Voice, and Photo Voice was fascinating in that it really helps you understand the social and dynamic context of how these experiences unravel in that context, how local youth see those experiences, what to them is important in those experiences, and how, with them, you can co-create a vision of what is the problem that they're experiencing that is leading to more mental health problems. It's through the eyes of youth that we can get their vision of what is their experience, how is that affecting them on an everyday basis. To also solve the problem, we need to put youth in the equation. We cannot have them as passive recipients of our interventions, but actually we need local youth to outline what they think are probable solutions and to help us co-create a vision of what they think is the solution to the problem, and how they position themselves in that solution. So Photo Voice is really a process by using photographs and then talking about those photographs, where youth can identify, represent themselves, enhance their community, and use specific photographic techniques to carry the message. In our conceptual model, and we have started with this conceptual model, we see the neighborhood, as I said before, and based on whether you are in that neighborhood as a majority or as a minority in terms of your status, that you're gonna experience, have experiences of social exclusion or discrimination, or you're gonna have experiences of social inclusion and support, or you're gonna have both from different people. And this is an opportunity to see them, how they play out in the neighborhood. How they play out also leads the youth to have specific behaviors, to have specific cognitions, and to have emotions about how those interactions play out and how they filter those interactions cognitively and emotionally. And that's what's going to lead to behavioral health symptoms. So based on that, we created what we call a multi-level mixed methods research design. And this multi-level research design, we combine with a participatory social justice research design. And I'm not going to spend a lot of time going through this, but the benefit of mixing these two research design is, in the first one, you really have, you're looking to get what is the relevance to youth, how their picture of what's happening in the design and methods has to be embedded in what youth think is their main problem, how they prioritize it, and then you amplify the voice of youth in really thinking about the processes that you want to pay attention, and how those processes, you know, become layers into the problem that they define, and in the layers in the solutions that they think could be for them. The other, participatory social justice, you know, is really bringing the eyes of the youth to collect data in a way that involves and honors their expertise as youth. Because as people that are in research or, you know, in scholarship or even in treatment or both, our experience as youth could have been very different than theirs, but also the times have changed so dramatically. We want to make sure that youth conduct the analysis and help us emphasize what are the needs they see and why are they saying that these are the solutions. Basically, the way we did this study was that we worked with 80 youth. We gave them 4 trainings and in each of the trainings, they provided 10 pictures. We gave them prompt for the types of pictures we wanted. And we worked with 4 different communities in Massachusetts. In year 1 and 2, we worked on the Photo Voice project, and I'm going to show you what that meant. The youth then in the second year presented to their community in community forums and key informant interviews what they had found, and together with the community identify the priorities. And then in years 2, 3, and 4, actually, we spend the time developing the intervention. I want to show you this because the first thing youth told us is it's hard to live in a community where the world sees these communities in a very stigmatizing and negative way. To really be part of these communities, and then when people only see the negative, it's really hard because they ascribe that negative and stigmatizing to you too as a youth. And so they talked about how they saw their communities as gang infested, you know, really having lots of problems in teen death, having prison, drug trafficking, the whole thing. The other really nice thing about Photo Voice is that it gives you an opportunity to use the photographs for youth to reflect on what's happening in their community and see it through the photos and get to know their community and the problems of their community and the assets in their community. It allows for youth to have a dialogue with others about what they're seeing and how they're experiencing what they're seeing in those photographs, and also for policymakers to actually see the images and then relate to how the youth are experiencing the phenomenon. This is to show you some of the photographs of Charleston, East Boston, Chelsea, and Revere, and to give you an idea of how youth can see assets and challenges in their community and how those assets and challenges are going to play out in what they're going to do. And so this you can see here all the way from transportation, all the way from seeing, problems in the upkeep of infrastructure, issues of safety, issues of lack of indoor teen recreational spaces, but youth are themselves the one that identify the assets and the challenges. Also want to show you a picture. This is something that the youth talk in the first meeting that we have when we are asking them to tell us about their community. First thing this youth wrote about in terms of Charlestown is how segregated it was. It also goes back, the upper class people only could live in places like Newton and Michon, and African Americans would live in the projects, and how they separated this in terms of where people live. This was also very instrumental into how we use the data that they provide us in terms of planning recruitment of youth in different areas of the local community. I'm going to show you how we integrated the 3 pieces of information, and then I'm hoping to move you to the intervention itself. The first piece that you see in the left is really the census map that actually draws how the youth in that community and the families are distributed by race, ethnicity. And you can see here how the green represents, the predominantly white neighborhoods. The blue is the Black neighborhoods. The pink is the predominantly Asian neighborhood, and then the gray is the predominantly Hispanic neighborhoods, but how segregated that was. And this is important because it really helps us then think about, if they're seeing this as part of the problem in terms of the census, it provides like, what are things that we should bring to problem definition that the youth want to identify. Here, this is a picture that one of the youth took from the Bunker Hill monument. And this was asking a photograph that what if you could change your neighborhood, what would you do? And what the youth said immediately is this neighborhood, it's diverse, but it's not together. It's sad because I wanted the neighborhood where I know people and I feel comfortable with people. And in this photograph, the youth is really talking about the segregation and how it makes him feel. So you can see here from the census map, and then moving next to the photographs that youth take, then you can integrate this in feelings that the photograph bring to place. And then lastly, they bring this information at the community forums. And there you can see the red dots, the green dots, and blue dots. And then they present what they have found of the problems. And then they ask the community to identify what is the priority. And then they decided that making housing more affordable was the priority. Here you can see also that this is not only what the problem is, but how the youth really talk and narrate the problem. I've noticed that since they built this hotel, there's more people. Everyone in Chelsea is like a family, and just seeing someone you don't know and haven't seen before, it just makes you feel weird. It's like 50-50 anger and confused. Why would they build a hotel in Chelsea? Why can't they use the money for something that would benefit the city? Chelsea is mostly a Hispanic and Latino community, and then once you implement a hotel, there's many white Americans coming in. So it's also how they see the clash between races play out in their community. But also, I want to say that this co-researcher, having youth co-research and really present the problem and also the solution, it's important because in a certain way you want to create interventions that that really have feasibility and acceptability, and that youth find it of importance to them. This was the experience we got in Photo Boys, that it produced results through the eyes of youth that we could have never told about, though, that the youth were really the narrators of what was going on, that they could identify the assets, the opportunities, and how this could play out for the intervention, and then identify their thoughts and feelings and get to know an awareness of those thoughts and feelings and how they could play out in terms of resources that they needed to seek out in the community and present to the community. I also want to say that this is really a new method of thinking about how to generate interventions. But the most important thing is that in this way, youth gain ownership of what is the problem, but also what is the solution to the problem. The only downfall to this issue, which I want to be very upfront with you, is that they could identify that what you thought was the intervention is different than what they want. In this case, for example, the youth didn't want a mental health intervention. In fact, they said, we're tired of people saying what we need is a mental health intervention. What we want is an intervention that really deals with issues of systemic neighborhood challenges rather than an intervention for us. We're not the problem. The problem is in the neighborhoods we live and the opportunities we have or resources we have in those neighborhoods. This left us to go all the way to LEAP, and LEAP is really the intervention we co-created with youth. Why do LEAP? Well, it's bringing the voice of youth to think about solutions to the problem in a way that addresses their mental health, but maybe in a different way than what we thought. We thought this would be intervention of mental health in the schools. You said, no. We want something similar to that, but that really addresses more the challenges in the neighborhood that we think have an impact in our mental health. They selected civic action, civic leadership as the important aspect that would make them more empowered and feeling that they had some control over what was happening in their communities and where they could play a role in resolving some of the problems. And this was also a way they thought they could bring other adults and policymakers to see what was affecting them and to see that the solutions might be different from the ones they were considering. So we here, one of the things we show in this, and I was fascinated to see that shift, was to see youth change from passive receivers of what was happening and seeing themselves as, these are all bad things that happened to us, as seeing also the resources that could be in their communities more from an asset framework, and also what could be done so that they would feel better, more active, and engaged in self-care. So this changes from recipient to activist, and it's a way of engaging youth to address factors that impinge upon their health rather than just receiving them. The curriculum that we developed with the youth really had three main components. One was learning about their community and selecting an issue to focus, interviewing people in the community about the issue so that they could learn what would be potential strategies of the problem, but also of the solution, and then developing an action plan together with the facilitators on this. And overall, they would learn about assets and challenges. They would have leadership roles and understand how youth-led movements have been so instrumental in changing so many things in terms of our environments and our communities. They would learn how to interview people in power and how to relate to people in power, and that they could play a role in those interviews. And then to develop an action plan and to work as a group where they could receive social support. The youth also ask for, this is the curriculum in, obviously a very brief outline that I can cover, but I want to show you how they really wanted to have the facilitators help the process of the first 7 sessions, and then they would take the last 5 sessions in terms of doing and lead those 5 sessions to take a leadership role. It really changes the experience of youth as having a problem to being part of the people that are trying to deal with the problem and resolve the problem. We actually think that this is our logic model, that based on doing this inputs of leadership, of communication, of promoting relationship building, we also added a component of stress relaxation, mindfulness. We've expanded the mindfulness component. You can see here, the expectation is that as a result, youth would have more leadership, more civic development. They would have more participation skills and civic beliefs. And that would give them things that the literature has said are so central for youth well-being: a sense of belonging in their communities, a sense of purpose because they are operating on trying to solve problems, leadership, better communication skills, not between only themselves, but with people in power and authority, more self-efficacy, where they have more of a self-efficacy to deal and control their circumstances, and better peer relationships. All that would take them to longer-term well-being. I'm not going to go too much into detail, but we did a pilot study. We've done 2 with Medco. We did one, with youth organizations, and this second with Medco. First of all, I should tell you that the program, 30 youth applied to participate in the program. We could only take 15, but of those 15, no one missed one single session. Youth were really, really excited with the project. They really liked doing this. Youth were 14 to 18 years of age. They really, in the responses to the, we only had pre and post assessment, and we didn't have a randomized trial because this was just a small pilot. But what we found is that youth improved in all of the areas in terms of movement from pre to post. The only thing that we saw is that they really wanted a lot more that had to do with them being in leadership. Multiple participants really said in Medco, I would say participating in this internship changed me a lot in a lot of ways. I was able to grow as a learner and was able to create something that I was proud of virtually. I also learned more about important events in history, activism, health equity, and more about my community. I think even by participating, I was able to learn more about myself and my peers. So it really, overall, youth thought that they were getting a better sense both of their community, of themselves, and of the other youth surrounding them, seeing more universalism in the types of structural problems they were confronting. So from this, we learned one, that ideally, when you're doing interventions for youth, you should have a voice both in the creation, but also in implementation of the programs, because they should be owned by them. I think the importance of neighborhood when we are thinking about the mental health of youth, we're so constricted to individual without knowing the neighborhood context and what can happen in that context and the experience in that context. And then the importance of having academic youth partnerships. And I would say, if possible, add policymakers, because this way you really bring the voice of youth, but you also bring the voice of people that can sustain the program and can see the development through the eyes of youth, and identify how to problem solve issues in their neighborhood that are challenges that they as civic leaders can take on. And one of the things we learned from this program is it's different things in different places. And so being flexible in how you use the curriculum to identify what in different places people want to change is the way to go. So lastly, where should we go from here? I really, I'm hoping that this presentation inspires you to disrupt the dominant model of individualized pharmacological treatment in mental health care in the US, that we need to be broader, much broader than that we need to bring the structural factors, because the issues of wealth, education, neighborhood conditions are all really part of the bigger picture. If we can only do so much in our clinical environments, if those things that are surrounding the everyday lives of this youth don't change, and that we need to more move to the community-based approach that breaks down the barriers and really thinks of mental health care as something that should be more equitable for everyone. The models we have are really not addressing the escalating problems. We keep on seeing more and more problems of suicide, of depression and anxiety. The system is so focused on changing the person rather than changing what's happening around the person, that I don't think we're really doing that well in tackling structural disadvantage, institutional racism, and the lack of opportunities that are central in how youth feel today. And that this is going to lead us to change the explanatory models of how we develop interventions, will require us to focus on social needs. I think what metrics of success, we've used a lot of metrics of success that are very much on symptom reduction. And I think maybe that's not the way to go, that we might need to change the payment policies of how we do services and allow for flexibility in regulations. We just published a paper in American Journal of Psychiatry talking about how we could optimize, given all the money that it's now given to communities. We have a lot of knowledge of what works in communities and what doesn't. There's been trials for the last 20 years. And we have data on what programs seem to work well. So I mentioned here 3: social determinants, school-based services, where we can do things that have proven that they move us in terms of decreasing mental health problems, and community-based initiatives of after-school programs or even school programs, including training paraprofessionals to help us expand the capacity of services. So overall, in ending, I just want to say I'm hoping that as leaders in the field, you advocate for policies and practices that are more responsive to the problems of racism and mental health issues that affect youth of color. I really feel we need to change the paradigm, that we support an overhaul of institutions and how we provide the services, take away the biases, and nurture issues in the environment and the neighborhoods that can really have a wider effect, and bring the voice of youth to support changes at the neighborhood and systemic levels, and encourage youth to use their cultural factors, because many of them we know make a difference in how youth feel. So I'm going to stop sharing and then open myself for questions.
This is such a fabulous talk. Oh my gosh, thank you. I hope we can hear the applause, and the gratitude. I'm going to open it up for questions. I won't take space. And I know Christina, yeah, there you go. You have your hands up. Go right ahead.
Great, Maggie, excellent talk and so interesting. I couldn't agree more. And as I'm not sure whether you were monitoring the chat, but everybody was like, yes, yes. Like everything that you were saying was very aligned. And I think most of us kind of are aware of how much these structural issues affect the kids. And I love how you're kind of engaging the people within the community to really be thinking about this. I'm wondering if you could drill down a little bit more about what you learned from some of these kids around the differences that might be needed for boys, for adolescent boys and adolescent boys of color. I really think in general, there's so much stigma, right? There's stigma around mental health. We know this, but our attention, I don't think, has been much on what men and boys may need in a unique way here. And so when you brought that up, it was really it piqued my interest.
Yeah, I think a lot of our CBT and a lot of our, interventions are very much developed with women, because depression and anxiety was very much in that line. I actually think, in this, I'm gonna go here off the cuff, because I mean, we haven't done this work, but one of the things we see is that boys find it very preachy, the approach of the types of interventions that we do, rather than more proactive. One of the things youth like very much, the boys like, is that this is more taking their input and deciding based on their input what is the problem definition and the problem solution, rather than recommending, doing exercises with them. I think I'm not very sure that youth want such a preachy thing. And once they hear, and this we've seen also with young adults, that they feel that once the person who's giving the intervention becomes very preachy, it's a turnoff, complete turnoff. So we're gonna have to think how to engage boys in a different way that doesn't seem like we're preachy and like we're telling you what to do, but rather that you generate what to do as part of the solution. So I think shared decision making is part of the picture here, but also thinking more like, should we change the type of things we do in some of these interventions to tailor it more to what boys want, rather than what we have heard from pretty much doing a lot of the interventions, mostly with women.
I so appreciate that piece. The other piece that I've been thinking about is, to your point that youth rejecting the individual approach of like, you need care, the problem is with you, and rather, thinking about the intervention at the community level, right, the neighborhood level. Obviously, this is all your work. What I'm challenged with as a clinical provider and thinking about the, looking at all the outpatient clinics within our child divisions, how do we make that shift? Like, for example, through Medi-Cal, there's an expansion in California that through CalAIM that now children can receive what's traditionally specialty mental health services without a diagnosis, right? So everyone's like, great, this increases access, but I'm still doing CBT, right? And so I'm still thinking about what are your needs, your individual needs, and how do I do symptom reduction, and how do I reduce risk? And certainly there are youth who need that individual approach, chronically suicidal, self-harming, who engage in substance use behaviors, right? I think there needs to be an individualized approach, but then as we're expanding services, not every kid needs me to intervene
Absolutely.
on that individual level, right? And so now we're going to have a huge need, but we don't have the intervention.
This is where peer use. I think peer use is a really, really promising approach to giving more services, and also helping youth that are still not in problem recognition, helping them transition to that. So I think peer use could be included as part of more community-based, school-based approaches. And what we are finding with, we're using more, not peers youth, but we're using also a lot of community health workers, where they actually give, more, expanded services, more psychosocial, but it's like an entryway for you to feel like, first, we recognize it's not you. There's a lot that's going on that will put you at risk. So we're going to give you strategies to deal with everything you're confront, or many of the things you're confronting, so that you don't get worse. But if you need more, then we'll pass you to the next level. But then we do it as a triage system, but it means that we have to move earlier in the sequence. We can't wait until people come to clinic because we get them too late, way too late.
Thank you for that. Dr. Fortuna, you have your hand raised.
Hi, Maggie. I know we have like 1 minute left, but
No, we can have 2 or 3 minutes. Don't worry.
yes. So yes, praise and I'm so agreeing with everything you're saying, as you know. And we're trying to create interventions here to do a lot exactly what you're saying, doing these sort of tiers of care and engaging youth in the co-design. How do you see involving families? Because a lot of times, we're seeing that we need to co-create some aspects that are family-centered and also include, structural and social determinants of health that are affecting the family. And
Yeah.
sometimes that's even trickier.
Yeah, I think one of the things that was to me fascinating was to have the family members come to the community forums and see the pictures of their youth. See the pictures of their youth because they were seeing the problems through the eyes of their youth. But the other good thing they saw is that some of the issues that youth were representing, it was not only their child, but actually it was very, prevalent in what the youth of that area were presenting. So if they were presenting, for example, issues of violence, you could see that other youth were talking. So to the parents, it was also eye-opening. And I want to say this is really important, Lisa, because we're finding from other work we're doing that parents and youth have very different perceptions of the problem and also the severity of the problem. So we're seeing parents think of the problem as something minor and the youth telling us that the problem is quite severe. So this is an opportunity to open that door for communication and having a more shared understanding of the problem of youth.
Thank you for that. I want to say that we are at our hour and want to recognize that you are willing to give us a couple more minutes and also want to make sure that others know that they can respectfully exit.
Yeah, sure. Absolutely.
Yes. So thanks everyone for being here today. I will not close the Zoom room, but if you have a minute or two, I know there's
absolutely.
More comments. Okay.
Yeah,
so appreciate your time.
Sure.
Dr. Martinez, if you're still on, I know you've made a comment and I think it's best if you addressed it instead of my reading it.
Yeah, and thanks so much, Dr. Alegría, for being here. It's always a pleasure to hear you present this and being very familiar with your work and seeing it presented. I still learn something new every time, so appreciate you. I just want to say, I think the idea of peers is so important, especially when it comes to our boys, to give them an opportunity to be employed as well. What we're seeing here in clinics and various groups is that the boys tend to be employed much more. Some of them were averaging in some of these groups like 30 hours plus a week that they're working outside of school. And a lot of times that's what's also interfering just structurally from them being able to attend services. But being able to provide an economic reason for them to be involved, whether through peers or whatnot, I think it's important to consider. And something that I think it's, structurally how to change that so it's part of how it gets paid. So Medi-Cal paying for this rather than, scrapping together funds through research projects or other means to do this. This should be part of the intervention through the system, right? So I'm glad you brought that up.
Yeah, I think peers and, there's several really innovative work that's being done on suicide, for example, where youth, for example, videotape, messages about suicide prevention, but work on it together. And it's a way of creating a support group, creating information for other youth to see that, everyone is having problems today. And like you're saying, paying the youth for some of this work, which would be I think a fabulous way of trying to make sure that they have some alternatives that are not having to work full time, because a lot of these youth do a lot of full-time work at night.
Thank you for that. So many comments of appreciation. Are there any last question? Just one. Yeah, is that okay?
Yeah,
Any
sure.
other? Okay. Oh, maybe not. People still processing. Going once, going twice. Okay.
Happy to come again and have just like an open forum for, different questions, because people might be thinking, this is a transformation. What we're asking, and thanks everyone, it's a transformation of how the system works. So it might really require thinking through how could it be done and what are the steps that we would need to be done. But I think it's very doable. I just think you have to be courageous and bold and look for funding in places that typically are not the ones we do, but I think this is a transformation we can definitely do. And we have a lot of knowledge, so we don't have to start from scratch. So thank you for having me, really appreciate it.
Thank you, Dr. Alegría, for all that hope, all the hopeful messages and the wisdom that you just shared with us.
And thank you, Lisa, for inviting me from the first time.
Take care, bye-bye.